So, so after each, this is a unique thing. We really want you to see if we can help you move your injection practices along in a way and have some practice and some feedback and be able to ask questions about it. So we're really excited about it, and we're hoping that you'll like it quite a bit. I want to thank Robin and Deborah from Becton Dickinson BD Canada about how great a job and how wonderful it has been working with them, and we're happy to brave their support to bring this to you. So I am just going to introduce Laurie Berard, who is going to be your speaker today. I have to read this, unfortunately. She has over 30 years of experience in diabetes education management and clinical research, working as a nurse manager for the Health Sciences Center Diabetes Research Program and a faculty member at the University of Manitoba Department of Medicine section of endocrinology. Currently, she is working as a consultant in diabetes management and clinical research operations. Laurie has dedicated many years volunteering with Diabetes Canada and has extensive experience with the clinical practice guidelines. She has received many honors and awards related to her work in diabetes. Take it away, Laurie.
Great, thanks. Welcome everybody this morning. And, I'm echoing. Am I still echoing? I just wanted to actually give you another little piece of information about about myself. So yes, I'm a nurse at the pharmacy conference, so thanks for accepting me. But why am I here today is because my oldest grandchild turned 11 in September. And when he was born was the first time I was at a conference about injection technique. And so after 30 plus years of diabetes, you know, I've spent the last decade of my life actually realizing that we're missing a really vital, important piece of providing good quality care to our patients. So I've spent a lot of time in this area. So let's move on. So this is Module 1. We're going to talk a little bit about setting the stage. So the learning objectives for Module 1 is what we want you to be able to do is understand how our patients are performing their insulin injections. So what do we know is currently happening? I want to give you some tips to help your patients improve their technique. So things that you can talk to them about. And of course, there are ways that we can continue to support people in a virtual setting, and that's where we are right now. So Ruth, I've set up a couple polls. Would you mind running the first poll for me right now, please? So what I want to ask you, I just want to gauge where you're at, is how often do you ask your clients about their injection technique? So you see people with diabetes. We know that individuals living with diabetes see their pharmacist on average, 50% of them see their pharmacist once a month. And of course, you're dispensing insulins and you're dispensing pen needles, and maybe you're getting questions asked about insulin pens because maybe they've lost them or there's a breakage. So we've got some numbers moving around. Getting there. Okay, let's end it now. Let's end the poll. Yeah. So basically what I see is that you are reactive. So meaning that you talk about injection technique primarily if they have a question about something that they want to ask you. And then that followed after that is that 20% of you make sure your clients are aware of proper injection technique. And then a small percentage of you have never done that. So let's see if we can move you along the way. So why is this important? So why this is important is that we recognize that we have a problem in Canada. So there's been injection technique surveys that have been done worldwide. We've been talking about them for years. I did one myself a few years ago, but we did that in a diabetes education center, so the results weren't horrible. But most recently this past year, we did a survey practice. We looked at injection practices in a population of Canadians with diabetes. Excuse me. We did an observational study. So we recruited primary care providers primarily. There was a few specialists in there. And what we did was kind of a one-time visit. We wanted to understand a couple of things. So we wanted to understand what physicians thought about injection techniques, But then we also wanted to understand what patients did and thought about injection techniques. So we recruited 230 patients, and they were on average 60 years of age. They had had diabetes on average about 16 years, and their A1C was 7.8% on average. And of course, they were all insulin injecting patients. So the first thing that we did was we asked the doctors involved. So how often do you assess injection technique? So we asked them a couple questions. So 96% of them reported that proper injection technique is very important to patient care. And we asked them another question that's not represented on this slide, but they had high confidence. 80% of them were very confident that they did a fantastic job in terms of counseling their patients around injection technique. However, they were honest with us, and 71% of them did not regularly assess injection technique. So that's kind of like what you're saying. Well, if someone says something to me about it, then I have the conversation with them. But in fact, even though they knew it was very important, they were not actually routinely checking their injections. And when we asked them again, what are the barriers? So you know this is important, and you guys are not surprised by this, because anything diabetes related is very complicated, especially in the primary care setting. They don't have a diabetes educator. They don't have a lot of time to go through all of this. And even though they're confident, they may not have resources, and they may not just feel like that they can get what they need in a short visit. So this is where I think doing a program like this is so fantastic, because I said earlier, we know that 50% of people with diabetes see their pharmacist on average of once a month. So you guys are so well positioned to really help primary care providers. And remember, there are 4 million people living with diabetes in this country, and about 10% of them have type 1 diabetes. And we think there's probably about 300,000 type 2 patients injecting insulin. Guaranteed, those people are not being followed in specialty care. They're maybe not even seeing an educator or a diabetes center on a regular basis. So that leads to, well, what are the patients doing? So there are 7 key areas that we really wanted to understand. So if you focus on the right-hand side of the slide, what you see is what we asked about. So we wanted to know how much injection force they were using. We wanted to know how big of an area of a particular site they were using. We wanted to know how long they left the needle under the skin. We wanted to know if they reused their needle. We know that our patients do not require a skin lift when they're using a 4 or 5 millimeter needle, but we asked about skin lift, and specifically we looked at those individuals who were using those shorter, finer needles, and to see what their practices were. And we know that a lot of our patients out there in the literature, about 50 to 60% of people have lipohypertrophy, and they love to inject into it. It doesn't hurt. So we asked about, do you have these areas? Do you inject into it? And then, of course, we asked a little bit about insulin needle length. So when you look at the right-hand side of the screen, you see the areas where there's a best practice. So a gentle force, a big site of injection within an area, under the skin for 10 seconds. Don't reuse your needles. Don't perform a skin lift with a smaller needle. Inject, avoid lipohypertrophy areas. And then the length of the insulin pen needle. We did pretty good, because I think we've got a really good uptake in Canada of 4, 5, and 6s versus 8s. But if you look at the percentage of patients that were making that error, the highest one was on injection force and site size. But then how many patients, if you go to this left-hand side of the slide, what you see is that of the 230 patients, they were all making at least one error. And in fact, some of them were making errors in all 7 areas. So we have a lot of work that we need to do. Remember, these are physicians that were confident they knew what they were doing, and they knew it was important, and these are their patients. We created a lot of aha moments when we reported this back. So why does all this matter? And it matters because there's been work done in the area of what happens when people make injection technique errors and their ongoing A1C control. So this is some work that's a couple years old by Gentile and company, looking at Italy. And what they did was they looked at almost 1,100 patients. Over 50% of them had lipohypertrophy. That 160 of them had documented injection errors. And you can see on the bottom of the slide that the number of errors in injection technique resulted in higher A1Cs. So people that had 6 errors had a higher A1C compared to the ones that only had 1 error. So injection technique, we know, matters, but how they are doing it is also really important. So what are the complications? We've been talking about injection technique for about 10 years in Canada. Just as a reminder, when you have poor injection technique, you have glycemic variability. Patients, their monitoring doesn't make sense. They inject it the same way, the same place, the same amount, do the same thing, and their numbers are not the same. They have unexplained hypoglycemia. They may hit an area of fresh tissue with an insulin dose that's gone up, because when they go into lipohypertrophy areas, they need more insulin to do the same job. They get bruising and bleeding. They get areas that may be having more pain because of the type of force that they're using. They get lipohypertrophy. So these areas of squishy, I call them pooches. So they're like little areas that are like bags under the skin that are like sponges, or they get hard balls. And so these individuals, they have problems with glucose control, they have discomfort, and they also have some issues with body image, because they get lots of bruising and bleeding, and then they're not wearing their bikini because they have this line of fat, as they call it, over top of their bikini line, and it really is lipohypertrophy for poor injection. And that's how we know that we can really change. We've lost the art of giving good education. We've been so caught up in all of the other amazing things that have happened in diabetes, fancy insulins, fancy GLP-1s, fancy devices, sensor-based technology. The basic principles of injection technique can make a difference for our patients. How do I know that? Because lots of work continues to be done in this area behind the scenes. So Mike Smith and his group in the UK did a study where they looked at structured insulin injection technique across centers in the UK. And they looked at use of an intensive education program and a switch to the 4mm needle, and they followed the patients for 3 to 6 months. And what they saw at what you see in the slide is that before the studies, that 75%, that there was 89% pre-study were injecting into lipohypertrophy. There were 75 patients, of which 89% were using areas of lipohypertrophy, and after the study, only 20% were using the areas of lipohypertrophy. Proper education, shorter needles reduced the A1C by 0.4. They saw a reduction in glycemic variability by 41%. And unexplained hypoglycemia fell by 40%. Now remember, if you add a DPP-4 inhibitor to somebody who's on metformin and SU, you get a 0.4% reduction in A1C. So this is a significant reduction, but there's even better work that was done in this area, and this is huge. So Mishnikova paper, which was done in Russia, looked at proper injection technique, and they had 3 specific groups. They had a group that they gave a shorter needle and good injection information. They had another group, they said, just do your own device, like needle length, and we're going to educate you. And then this control group. And they demonstrated a 1% reduction in A1C with proper injection technique with a 4mm needle. That is better than any oral agent that you add on to someone's basal insulin. That's huge. And when we said that to primary care providers, we really caught their attention. If it's simple as making sure that people are injecting properly, and that they're not reusing their needles, and that they're rotating correctly, and everything is, they're not using long needles because they can hit intramuscularly, and I can reduce my patient's A1C by 1%. I need to think about this. This is huge information. This was a really well done study. It was randomized. And again, remember, this A1C reduction is better than adding on another agent. And in fact, when you improve insulin technique, you will reduce the amount of insulin that an individual requires. So there's less cost to the patient. I'm not needing another agent, less insulin's being used, less life frustration because they don't have the unexplained hypoglycemia. The glycemic variability is reduced. So really important results. So that's just a very quick overview. What I've tried to say to you is it's important we stop talking about it. We started talking about it 10 years ago, but in primary care, we still have a problem. There's not enough support. There's not enough time. Patients are still making a lot of errors. They're using lipohypertrophy areas. Their A1Cs are not controlled. We know that. So really, we're injecting insulin. We might as well stop in some ways because it's just not doing its job. So we've been trying to help. So I share the FIT recommendations. So we fitfordiabetes.com. There's a lot of really great information, including our FIT recommendations. Diabetes Canada has got recommendations around diabetes management. And of course, our hosts for today, BD, have created a lot of educational tools specifically around their needles and how they can help with improving injection technique. So what about you guys? So anybody who knows me knows I'm a huge fan of the pharmacists. They're always the person that sees the person living with diabetes. So you can impact change. And while you recognize that you answer questions, you can be a little bit more proactive. You can ask your patients some simple questions like, has anybody even ever talked to you about injection technique? You'd be surprised at how many people have just had their one-time insulin injection discussion and no one's ever asked them about it. And how you inject is as important as what you inject. And you still don't have to touch them. You can just ask them these questions. I can review your injection technique with you to make sure you're getting the most from your injections. Here's 5 key points. And I like when we have a little checklist of 5. So the questions you can ask is, are you using the shortest needle, 4mm? And we like the contoured or flat-based needles. So which design? We know that there's an increased risk when we use a posted needle in terms of pain, bleeding, and potential for intramuscular injection. And you'll hear more about that in a subsequent webinar. Are you ever looking for lumps and bumps? Do you touch yourself where you inject? What does your site look like? Does it feel hard when you're in the shower and you got some soap on your fingers? Are your blood sugars pretty regular, or do you see some ups and downs? Does it hurt when you inject? Do you rotate? So this is probably the easiest question. Where do you inject your insulin? And when they point to one spot in one area, it's golden. You've got so much that you can ask them. And that's what a lot of people do. They have their favorite spot. They don't go into multiple places. And whatever site they're using, we want them to use a postcard, not a postage stamp. And that's what they typically do. Every body part that they use, whether it's their abdomens, their thighs, and not recommended are their arms. But in each of the areas, or their upper body is good, they have a postcard size site they should be using. Other questions you can ask them are you lightly applying pressure to prevent an intramuscular injection? What does the skin look like underneath? Is it dented? It should be like sliding their needle into a pound of butter, not jamming it into a frozen pack of butter. So is it slid in? Is it gently against the skin? When they press too hard, they may hit muscles, they'll get bruising. And then again, we have options in terms of needle choices to make that easier. And we can't emphasize enough best practices that they use a new needle for each injection. And this is something that people, especially in Ontario, because needles are not covered, they may not do, but they need to understand that if they don't change the needle, they increase their risk of lipohypertrophy. Okay, so your checklist is: what needle do you use? Show me where you inject. How often do you change where you inject? Do you have lumps or bumps where you inject? And you don't have to touch them. Lots of times you can even see it. How much pressure do you apply? And do you ever reuse your needles? So these are your 5 best practice things to take away in terms of what you can do. We have developed a lot of really robust education tools around injection technique. On one side of the Fit Inject Technique Plus is guides for you as a healthcare provider. And on the other side, you can give a patient-facing information. So for example, you see proper rotation here. I mentioned that we don't recommend the arm for self-injection. You can see how they could do rotation, and then how they should be applying pressure, what type of needle they should use, making injections more comfortable. And these are available for download at www.fitfordiabetes.com for anybody that joins the website. So when we talk about this new idea, and you will hear more about this in a subsequent webinar, we have this new idea about the too much force. So there was no tool, but on the left-hand side of your screen, what you see is that you don't need to dent your skin. So you can see with a posted needle, it needs to just sit at the top of the skin, but most of our patients are jammers. So they're not gliders, they're jammers. And so they're actually injecting so hard that they have a bit of an indentation with the post. Hence, we can encourage them not to be jammers, and we can switch them to a contoured or flat-based needle. We can encourage proper rotation, and again, this is from the FIT recommendation. And then in terms of, we want them to be using the post card. So that kind of brings me to the end of what I wanted to share with you today. I'm going to ask Ruth to run another poll. At this point, I just want to see how we have uptaked this knowledge. So Ruth, can I get you to run that poll for me, please? So I've given you a really quick overview. I've sort of said, there's a problem. We know there's a problem. We know what the problem does to patients in terms of their diabetes control. We know what the errors are. We know that we need to do a better job. Here's some very basic things you can ask your patient. But my question to you is, upon the end of today's presentation, as you move forward, what will you do? Will you ensure all your patients are using the right insulin needle? That's a start. Will you ask your patients about their rotation habits? Will you make sure you discuss rotation? Ask your patients if someone hasn't checked their site, or you'll make sure that you have education material accessible. So I've asked you to pick your priority. Maybe you want to do all of these after today. Maybe I have, enlightened this. But if there's one thing that when you go back to the counter tomorrow that you are definitely going to do, please share with me what that is. I always feel like I need to have music playing when polls are running, Ruth. I don't know. It's like do 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 do. We're getting there.
Yeah, we have 60% voted.
All right, we want to get up to 70, I think. 70 is always a nice number. There we go.
Oh, look at that. We're at 75%.
All right. Can we get to 80? Would 80 happen?
On click.
There we go. go. Okay, let's stop it now. We're at 78%. So thank you for everybody to participate. So that's amazing. So the priority is making sure you have education material available, and that's great. It's a great place to start. Rotation of insights, needle reuse, another priority, followed then by ensuring patients are using the right length of needle. That's great. See if someone else has helped them and ask them about their rotation habits. So thank you for sharing that with me. So it's great to know that there's something that you know you can do tomorrow. All right, so after you've been with this particular webinar, here's what how you can apply what you've learned. So you've already talked about what you want to do, what change you're going to make. You can download the IT checklist. You can review it with a couple of patients in the upcoming week. Do a little trial in your practice and see what you find. And then when you come back to module 2, which is done by my colleague Rob Brosco in a week, you can share what you've learned in module 2 session via the chat box. So what that means is you'll share what you've learned in your week since this webinar in the chat box at module 2. So be prepared to share. And so with that, I think I get to stop here and remind you to join us next week for module 2, injection error, too much force. Rob will go over that with you. And I think we have a few minutes left, Ruth, if we have any questions that I'd be happy to answer.
Yes, we do. We have a comment actually from somebody. They're really amazed at how many patients come to them and say that the CDE has advised them to reuse needles, which are.
Yeah, so I can take that as a comment, and I'm a believer that best practice is single needle use. I personally never encourage patients to reuse their needle. However, when I have patients that tell me that's what they're going to do, I always give them the risk associated with that. And then it's their choice, but I would never encourage somebody. However, I have to accept what they tell me. So if they say to me, listen, I have type 1 diabetes, I take 4 shots of rapid acting insulin a day. I'm not putting a new needle on. I put one on in the morning, I take it off at night. I go, okay, just make sure you prime. Like if you're not going to follow best practice, please make sure you prime so your needle's not blocked, and you'll get more risk of lipohypertrophy. So I mean, I'm surprised that someone would say, yeah, go ahead, because I think we understand the risks of needle reuse. But certainly people living with diabetes have a choice. Our job is to make sure that they understand the consequences of their choice, right?
Exactly.
So that's a great question. So thank you for that.
So this is really helpful here. This question here, I've asked a few patients to assess their injection technique, but they say, no, it's okay. And how do I encourage them to let me help them? So this will be good in the homework, right?
Yeah.
We want them to continue to reach out. What can you do to help them?
I would normalize that. I would say, hey, you know what? I just went to a webinar and we realized that a lot of people who are injecting insulin have never had a refresher. And some of them are always injecting into the same site, and they have an area there that may not absorb, and their blood sugars are not doing as well as they'd like. So is that something that you think we could talk about? And I mean, I've been in diabetes for a long time. My patients that I looked after for a long time didn't want me to touch them because they knew me too well. They didn't actually even want to show me the areas. So I put it back on them and sort of said, the next time, just check the area that you're in and use soap on your fingers when you're having a shower and make sure that the tissue feels normal and see what you find. And let's talk about that the next time that you see me. They'll feel the balls, they'll feel the squishy area. And then that enlightens them to think about what other help they could perhaps get.
Yeah, maybe just give them a little piece of information.
Yeah.
Someone's asking if you could go over the postcard technique one more time.
So we have 4 sizes that we talk about when we assess injection technique. So most of our patients use a postcard area, or they might use a credit card area. But what we really want them to do is the quadrants of your belly, the top of your thighs, the back of your buttocks. We want them to rotate within an area that's the size of a postcard. I know most of us haven't seen a postcard for a long time, but a postcard is a lot bigger. And so there's a lot of, as my friend Gail McNeil says, there's a lot of geography in all of the different injection sites. Make sure that they're not just using one tiny little corner, that they're spreading their injections over the entire, so the 4 quadrants of the abdomen, that they're spreading their injection within the quadrant, within the top of the thigh, that they're not going to the same right upper corner or left lower corner every time they inject. Get them to rotate within their sites. So rotate sites and then within their sites.
Perfect.
There's a nice comment about needles get contaminated, dull and painful. Absolutely. Pain speaks. I understand cost issue and perception of wastage as well. I mean, diabetes is an expensive disease, right? So, so people are, they're trying to figure out how to save costs. And I'm always shocked as a Manitoban that Ontario doesn't cover pen needles for patients. Like,
oh, I know. We give them the insulin and what are you supposed to do? Drink it, right, guys? I used to say that all the time.
Yeah.
So maybe you could comment slightly on the pharmacy technician. I'm a very strong proponent of using pharmacy technicians to help you with your patients because they're part of the team.
Right. And the pharmacist is busy. And I actually think that even if you empowered your pharmacy technician every time they handed over a box to sort of say, hey, you know, we just have a few questions we'd like to ask you about your injection. And even if, I mean, again, within their scope or everybody's comfortable with it, why not let them start by asking the questions? And then, you know, do you want to talk to the pharmacist about it? I think that, you know, even just also empowering someone that if you're pulling a box of 8mm needles off of the shelf, make sure that there's really, some patients like them and they continue to use them, but there's a risk attached to an 8mm needle. So maybe no one's ever entertained that with them. So could the technician then flag the pharmacist to say, hey, you know what? This person's still using a longer length of needle. Do you want to have a conversation with them? You know, so just give them little ways that they can kind of help create the aha moment that there needs to be a bigger discussion, if that makes sense.
Definitely. Yeah, no, I think that they're right there. They often have a closer relationship with the patients too. Like they see them all like, oh, hi, how are you? And you know, just or they can be really good ambassadors.
I think so, yeah.
I find, oh, the pharmacist talked to so-and-so the other day and she was really happy with what they said. So, you know, just simple little things. And I think what's coming across here is it takes time, right? It takes time for you to be comfortable in asking, but it also takes time for people to realize, oh, you mean you're not going to tell me to take my shirt off, right?
Right. I have one thing to say before we close, and I know we're at time, but when I conducted the survey in Canadian diabetes education centers about, I don't know, probably close to 10 years, well, not quite 10 years ago, probably about 7 years ago, these were diabetes educators that saw their patients regularly and were experts. Patients reported lipohypertrophy at about 26%. They were confirmed by educators at 13%. So I also think that we've stopped teaching people how to find lipohypertrophy. So they didn't not necessarily know what they were looking for. But again, it's just very basic comments is, do you rotate? If you don't rotate, you probably have some lipohypertrophy. Do you reuse your needle a lot? You're causing some damage. It's, you know, it's going to shred the skin. Like these are sort of things that, and I just ask patients to check themselves, right? Like I don't need to touch you, but I'd like to touch you if you let me, but you can check yourself and then tell me what you find. So I think it's that we stopped teaching this in diabetes, and that's really been unfortunate because apparently it didn't go away when we switched off of beef pork insulin, which is what many of us thought. And poor technique leads to poorer outcomes for our patients. So just how is important as what, and we can reduce A1C with better technique.
Yeah, we can make a big difference. Thank you, Lori. It's been amazing. I like this short, sweet, get to the point. Thank you, Dee, for yours. I look forward to seeing you next week. The recording will be placed in the course. You can always access it probably tomorrow, and you can always access it there. There's a couple of questions for you to knowledge check questions to make sure that you picked up on everything. Feel free to get into the discussion boards, ask any questions, aha moments, whatever you'd like to share with others. And I look forward to seeing all of you next week.
Great.
Thanks, Lori.
Bye, everybody.
Bye. So after each, this is a unique thing. We really want you to see if we can help you move your injection